So nystagmus can be a little bit difficult topic if you are studying it alone, but I'm not going to leave you to suffer alone. So I will be with you discussing everything about nystagmus, how to assess, what are the different cases of nystagmus, what are different types of nystagmus, and how to manage a case of nystagmus. So let's get started immediately. What is a nystagmus? Nystagmus is a rhythmic abnormal eye movement. You see, it is oscillation, rhythmic abnormal eye movement that has two components, one slow phase and one rapid phase. The slow phase will be driving the eye away from the target or away from the primary position. So this is the fast phase, nasal, or the slow phase is nasal. So this will be one phase, or the first phase. It is the slow phase, will be driving the eye away from the target. And then there will be corrective phase that will bring eye back to the target. Again, there will be slow phase driving the eye away from the target, and followed by corrective phase. This corrective phase can be of same speed or can be of higher speed, which drives the eye toward the target again. This is called the nystagmus. A nystagmus can be horizontal, vertical, or torsional, or combination of these movements. Okay, so in this case, this patient has horizontal nystagmus. But what are other kinds? Vertical, torsional, or combination of these movements. The nystagmus can be jerky or jerk. This jerky means it has a fast phase. So jerky nystagmus means that the corrective phase is fast, like this patient. This patient goes slowly to the right, but return rapidly to the left. So this is a jerky nystagmus. Okay, so or pendular means that it has the phase, two phases are of the same speed, both are slow. It has a variable amplitude and frequency, and we will discuss this later now. And it can be worsened or improved by gaze position, nystagmus, or covering one eye, which is the latent nystagmus. So this the like overview of a nystagmus. Let's discuss the terminology. So I'm going to tell you this nystagmus is jerky or pendular, has high frequency or has low amplitude. You would understand what do I mean. So regarding the terminology, we have different terms used to describe the strabismus. The first term is called the conjugate or disconjugate. What is meant by conjugate or disconjugate? If both eyes have nystagmus, which has the same criteria, same everything, same direction, same waveform, same amplitude, same frequency, both beating to the same speed, everything is similar, then we call it as conjugate, like this. Both eyes move together in the same way, in the same manner, by the same speed, in the same direction, in the same frequency. If they are different from each other, we call it disconjugate, like this. The right eye has low amplitude, while the left eye has high amplitude. We will come to the amplitude now. Okay, so both of them are not similar, they are different. And this can be important sign, as we are going to discuss later in the spasmus nutans. If the both eyes are having disconjugate nystagmus, you may think of a serious condition, life-threatening condition, such as visual pathway glioma. So this is for the conjugate or disconjugate. Regarding the direction, the nystagmus can be horizontal, like this, beating in the horizontal direction, or it can be vertical, beating in the vertical direction, or it can be torsional, like seesaw nystagmus, one eye elevate and intort, and one eye depress and extort. So this intorsion and extorsion are, or this rotatory nystagmus, it is a kind of torsional nystagmus. So this is one thing about the terminology of nystagmus. The other thing is the waveform. Is it a pendular or jerky? Pendular nystagmus is when the eyes beat to and fro by the same speed. It has the same speed in the both movements. But jerky nystagmus characterized by slow phase and rapid corrective phase. And those patients has this high frequency, low amplitude nystagmus. You can see that the eye as if it is vibrating on its same direction, in the same position. This is what's called the spasmus nutans. We will come to this later on. But jerky nystagmus has a rapid phase and slow phase. Amplitude, it can be large. So the eye, this is a small amplitude. So you can see that the eyes vibrate in the position, doesn't move a lot of, or doesn't move that much. This is a low amplitude. It will be how much oscillation or how much the eye moves in each oscillation. Is it large space or small space? So this is a small amplitude, and this is a larger amplitude. So the movement of the eye is taking much space, or moving that more much, or more in the left side. So this amplitude representing what will be the distance that each eye moves. And then we have the rest position. So the rest is what will be the direction of movement which will cause the nystagmus to be lessen, or to dampen, or to be the minimal. Is it the primary position or a null zone? What is meant by null zone? It is the zone where the nystagmus movement is the least. So if the patient has the least nystagmus when he looks to the right, we say that the null zone is to the right. Okay, so this is the rest. Frequency, as I told you, high frequency means that it will be the high frequency means that how many, not how much distance like the amplitude, but how many oscillations occurs per second. Like if they are oscillates very rapidly like that, this is called high frequency. If they oscillate very slowly like that, it is called low frequency. So how many oscillations per second is the frequency. How much distance the eye moves per oscillation is the amplitude. So don't confuse between both of them. Okay. Do you need me to repeat again? Conjugate or disconjugate when the eyes are similar or dissimilar in the directions and waveform and amplitude. Direction is the movement of the nystagmus movement, whether it is horizontal, vertical, or torsional. Waveform, whether it is pendular or jerky. Amplitude, whether it is large or small. Rest, is it in primary position or the patient assume a specific null zone. This is very important for the management of nystagmus, and we will discuss this in the last slide. And the frequency, whether it is high or low. So what is the classification of nystagmus? We can classify the nystagmus according to the pathogenesis and onset into physiological, early onset, and acquired nystagmus. Physiological, early onset, and acquired nystagmus. So what are the different types of physiological nystagmus? There is the vestibulo-ocular reflex, the optokinetic nystagmus, the caloric nystagmus, and post-rotatory nystagmus. For the early onset nystagmus, there is the infantile nystagmus, sensory nystagmus, latent nystagmus, and spasmus nutans. And finally, for the acquired nystagmus, it will be the gaze-evoked nystagmus, seesaw nystagmus, downbeat, upbeat nystagmus, periodic alternating nystagmus, convergence retraction nystagmus. Do you remember when did we mention the convergence retraction nystagmus? What is the disease or symptom characterized by convergence retraction nystagmus? Yes, exactly. The dorsal midbrain syndrome or the Parinode syndrome. Okay, so let's now overview these kinds of nystagmus. So if you are just reading them alone, they will be very painful. So let's try to break them, try to understand them, and know what is the differences between them. First of all, the vestibulo, starting by the physiological. So we will talk about now the vestibulo-ocular reflex. The vestibulo-ocular reflex is a reflex movement that will keep the eye, that keeps the visual image stable on the retina during the brief or high frequency rotation of the head. Like now, if you are watching me now, so just to try to tilt your head to the right, like if you are sitting like this is you, and this is your eyes. So try to now tilt your head to the left. Do you see that the screen, the nystagmus and the vestibulo-ocular reflex wards are also rotated to the left? No. Why does this? Why does this occur? Because once you rotated your head to the left, there was impulses in the neck muscles and in the face that will send the impulses to the inner ear that is responsible for the maintaining the equilibrium. These impulses will pass through the vestibular nerve to the vestibular nuclei in the brainstem that will send the impulses to the ocular cranial nerves in order to do intorsion or extorsion of the right eye and the intorsion of the left eye, so that you will be able to see the words not tilted. So this is a test called the vestibulo-ocular reflex. This is physiological, normal physiological. So patients or normal individuals can show vestibulo-ocular nystagmus. So this appears on rotation of the head. Vestibulo-ocular reflex is controlled by the vestibular system of the inner ear, namely the semicircular canals, utricle, and saccule. So let's see this video. Third. So to see the vestibulo-ocular nystagmus. So the patient is looking to a target, and we trying to rotate the head or tilt the head. During brief movement, or rapid brief high frequency movement of the head, there will be some vestibulo-ocular nystagmus. Let's see it again. This vestibulo-ocular nystagmus occurs due to, don't know why doesn't work. Strange, it doesn't work. Okay, no problem. So this occurs, this vestibulo-ocular nystagmus occurs due to rapid momentary high head movement due to the vestibulo-ocular reflex. This is totally normal, and this is totally physiological. The second thing, or the second physiological nystagmus, is called the optokinetic nystagmus. It is a movement of the eye in response to large moving visual field. Like if you are rotating a drum, an optokinetic drum in front of the patients. You remember this word, optokinetic drum? We said it the last time in the assessment of the visual acuity in children. So when we are rotating a optokinetic drum in front of the patient's eye, there will be initial smooth pursuit movement. Smooth movement with the direction of movement of the drum, followed by rapid corrective saccadic movement to the primary gaze or the direction of interest. Let's see. So when we are rotating the optokinetic drum in front of the patient's eye, the eye has two nystagmus or optokinetic nystagmus. This optokinetic nystagmus has a slow phase or pursuit movement with the direction of the drum. And there will be rapid corrective phase against the direction of the drum toward the direction of primary gaze or direction of visual interest. And if the patient has asymmetrical optokinetic nystagmus, so this means that the patient has a problem. This asymmetrical optokinetic nystagmus can be due to lesions of parietal or parieto-occipital cortex. And in this case, it will be associated with homonymous hemianopia. Unlike the patient with occipital lobe lesion, there will be homonymous hemianopia, but without optokinetic nystagmus asymmetry. So when you are rotating the optokinetic nystagmus from above, from right to left or left to right, up to down, down to up, it should be symmetrical. But if it is asymmetrical, you suspect a lesion in the parietal or parieto-occipital cortex. So this will be very important. And in this case, this will be associated with homonymous hemianopia. Unlike if there is a lesion in the occipital lobe, it will cause homonymous hemianopia, but the optokinetic nystagmus will be symmetrical. Okay, easy. So remember, the optokinetic nystagmus will have a slow phase in the direction of movement of the drum and rapid corrective phase against the direction of movement of the drum. So this is the optokinetic nystagmus. What will be the third physiological type? Very important and very commonly asked in the exams, which is the caloric nystagmus. A caloric nystagmus, it is a subtype of a vestibulo-ocular reflex, but it is caused by a specific stimulus, what's called caloric stimulus. We are stimulating the horizontal semicircular canal in the inner ear with warm or cold water. We are pouring water, just warm or cold water, in the ear canal to create a convection current in the endolymph of the semicircle. So what will be the response? In normal individuals, when we are pouring cold water in one ear, there will be horizontal fast phase away from the ear, like that. So this is the patient. We are putting water, cold water, in the right eye. There will be rapid phase away from the eye and then slow phase toward the eye. Sorry, this is the cold water, this is the warm water. When we pour a warm water here, we are putting warm water in the right eye, there will be the fast phase away from the ear. So we are putting the warm water in the right ear, it will be fast phase away from the right ear. And when we put the warm water on the left ear, there will be the fast phase away from the left ear. On the other hand, when we are putting cold water in one ear, the horizontal phase will be away from the ear. So I'm thinking that yeah. Just hold on for a second. So there could be a problem in this images. So I will remove them. So, but the words here are normal, or they are correct. So if we are placing a cold water in one ear in the horizontal fast phase will be away from the ear. While if we are putting warm water in one ear, the horizontal fast phase will be toward the same ear. So to remember them, we just say the mnemonic cows, cold opposite and warm same. So the movement of the eyes will be to the opposite direction if we are putting cold water. It will be to the same direction if we are putting a warm water. And the question that appears always in the exams is that the caloric nystagmus is absent in the brainstem death, or it is absent. So it will be absent in comatose patients. Is it absent in comatose patients? No. If the patient is comatose, had loss of consciousness, he will still show the caloric nystagmus. Caloric nystagmus will be still there, so it will be present. The only condition in which the caloric nystagmus disappear is the brainstem death. Okay. So if there is a brainstem death, there is no nystagmus. Let's just remove these images because they are not very good. Okay, so this is the caloric nystagmus. Don't forget, cows, cold opposite and warm same. This will be helpful to remember it in the exam. Okay, so the third kind of physiological nystagmus will be the posterotatory nystagmus. A posterotatory nystagmus is a nystagmus that occurs after rotation. So it occurs after rotation of the body. It is a reflex, transient, conjugate, jerky nystagmus, conjugate, so it is similar, jerky nystagmus that occurs after the whole body is passively rotated around the z-axis and then decelerated to the rest. The nystagmus that occurs in this situation has the fast phase in the opposite direction of the previous rotation. So let me show you this video of this patient or this individual. They are just playing, doing a rotation. And then checking his eyes. So look at his eyes. This is the post-rotatory nystagmus. This nystagmus has a fast phase which is against the direction of the previous rotation. Got it? Okay, so these are the 4 kinds of physiological nystagmus. Again, let's remember the vestibulo-ocular nystagmus, the optokinetic nystagmus, the caloric nystagmus, and the post-rotatory nystagmus. Let's now discuss the most important one, which is the infantile nystagmus. So if you want to do just one nystagmus that is commonly present in the exams, it will be like the infantile and the seesaw nystagmus. Those are the most important for the MCQ exams. And why it is important? Because it is the most common. Like by the early onset nystagmus, we mention or we mean the childhood nystagmus. Usually the nystagmus doesn't present in the child is not born with nystagmus, or the term congenital nystagmus is not that correct, but it is usually developed in the early childhood. The most common is called the infantile idiopathic nystagmus. And as the word implies, it appears in the first months in life, and it is idiopathic, so there is no known reason. This kind of nystagmus is the most common type of nystagmus present in young children, followed by the congenital sensory nystagmus. So both of them can be very similar in clinical picture. So if you see a child with nystagmus, first of all, exclude the sensory causes. If there is no sensory causes, so by exclusion, it will be idiopathic infantile nystagmus. Okay, it is present from infancy, but can be recognized a few months later into life and may be evident only after the child has reached several years of age. And the idiopathic infantile nystagmus is almost always bilateral, conjugate, horizontal, even if it is up or down gaze. How is so? Like if the patient has up gaze nystagmus or down gaze nystagmus, so don't always think that a horizontal nystagmus will beat like that. Even if the patient is looking up, it will beat horizontally. Looking down will beat horizontally. So even it doesn't always have to be in the primary gaze. Can beat horizontally in up and down gaze with little variability. And so this will be the characters of infantile nystagmus. And for other features of infantile nystagmus, this can be summarized in the word congenital. This is very important. First of all, C. What is the C? Is convergence. So convergence and eye closure dampen the nystagmus. If the patient is looking to a near target, the nystagmus will decrease. If the patient closes his eyes, the nystagmus will decrease. So this is the C. What is the O? Oscillopsia is absent. So these patients don't report the C vibration of the things around them. They don't complain of oscillopsia. Okay, so they see everything steady, no problem at all. N, which is the null zone. Null zone is present. And this means that those patients can be subjective to surgery so that we can correct the nystagmus. We can correct the nystagmus by adjusting the extraocular muscles to the null zone, as I'm going to show you later. So this will be, there is a position where the nystagmus movement is the least. G is gaze position, which doesn't change the horizontal direction of nystagmus or the gaze uniplanar. If the patient looks up, looks down, looks right, looks to the left, still the nystagmus is horizontal. E is equal amplitude and frequency in each eye, which in other words, it is conjugate. Conjugate nystagmus. It has the same amplitude and frequency of both eyes. N, which is near. The near acuity is good because the patient tend to do convergence, as convergence will dampen the nystagmus and increase the time of placing the target over the fovea, which is the foveation time. I is the inversion of optokinetic response. So there will be asymmetrical optokinetic response, or there will be a reverse optokinetic response. Oscillopsia means a vibration, like they will see everything around them vibrating. Or shaking, everything around them shaking. They don't complain of oscillopsia. Unlike, for example, patients with upbeat or downbeat nystagmus, they will see them like everything around them move up and down. Turning of the head to achieve null point, or the patient assume it will be like a compensatory head posture. The patient will try to look for a position where they have the least nystagmus movement, which will be the null point. This is infantile nystagmus A, abolish, often in the sleep, usually decrease in sleep. And L is latent nystagmus or occlusion nystagmus occurs, meaning that by occlusion of one eye, the nystagmus of the other eye appear. So this sometimes happens. Okay, so don't forget, these are the features of congenital nystagmus or infantile nystagmus. Remember them by the word congenital. Another type of sensory nystagmus, in early onset nystagmus, is the sensory nystagmus. And you can expect why does it happen? Because of the sensory deprivation. There is no sensory impulses coming to the eye. So this is the sensory arc. You remember when we talked about the for development of binocular vision, we have to have a normal motor pathway and normal sensory pathway. Both of them will affect each other. So if the patient doesn't have a normal sensory pathway, this will affect the motor pathway, causing nystagmus. So let's say that the patient in the first three or 4 months, they have any kind of sensory deprivation, any kind of blocking to the sensory stimuli, they will lead to sensory nystagmus. It will be the same like the infantile nystagmus, like it appear in the early life in 3 to 4 months, but it is due to anatomical disorders of the eye, like there is a pathology, there is a problem, not idiopathic like the infantile nystagmus. So what are the kinds of these visual disorders? Remember the 5 A's mnemonic. A, aplasia or hypoplasia of the optic nerve, like those patients with optic nerve hypoplasia will present with sensory nystagmus. Leber congenital amaurosis, aniridia, achromatopsia, ocular albinism. All these 5 A's are the most important reasons for development of sensory nystagmus. But they are not, this is not an exclusive list, because it can also cause due to congenital cataract, due to ptosis, if it is complete ptosis obscuring the visual pathway. So the sensory nystagmus can be due to these reasons. The other cause of early onset nystagmus, we mentioned it in the congenital esotropia. We said it is associated with latent nystagmus, and we also mentioned in the infantile nystagmus, we said it will be associated with latent nystagmus. So what is meant by latent nystagmus? It is a benign condition characterized by early onset conjugate horizontal jerky nystagmus that only manifests after occlusion of one eye. So it doesn't present under binocular condition. Okay, it does not present under or does not manifest under binocular condition. If the patient under binocular condition, he is normal. You just occlude one eye, the other eye show nystagmus. And the direction of nystagmus is always pointing to the uncovered eye. It's always toward the direction of uncovered eye, which means that the direction changes depending on which eye is occluded. And usually it's associated with congenital esotropy, as we mentioned, and dissociated vertical deviation. So let's see this video of a patient with latent nystagmus. Do you see the increasing in the nystagmus after covering one eye? So this patient has infantile esotropia. On covering one eye, there will be latent nystagmus. You see, very clear. And this nystagmus is beating toward the uncovered eye. Another very important type of early onset nystagmus is the spasmus nutans. Spasmus nutans is a specific type of infantile nystagmus, which is characterized by three main features: small amplitude and a high frequency nystagmus. It is a pendular nystagmus, small amplitude, high frequency pendular nystagmus associated with head nodding. Head nodding and abnormal head posture present in the first year of life. Let's see this video. So this is a child, show head nodding. So again, spasmus nutans is a high frequency, low amplitude pendular nystagmus associated with head nodding. So is it normal or abnormal? It can be benign condition. It is relatively benign condition that usually resolve in the first decade of life without residual visual acuity or without significant or with or without significant refractive error. However, the important thing about spasmus nutans that it is symmetrical. It should be symmetrical. It should be conjugate between both eyes. If it is markedly asymmetrical, or if there is only involving one eye of spasmus nutans, please always consider optic pathway gliomas. The optic pathway gliomas, optic nerve gliomas or visual pathway gliomas can cause the same picture. So in this case, for patients with spasmus nutans, neuroimaging is a must. So again, spasmus nutans is a high frequency, small amplitude nystagmus with head nodding. Those are, so we covered the early onset. The early onset is now, to recap, the infantile nystagmus, the sensory nystagmus, the spasmus nutans nystagmus. So these are the different types of sensory nystagmus or of infantile and early onset nystagmus. Other parts of nystagmus or other kinds of nystagmus are the acquired nystagmus, starting by the gaze-evoked nystagmus. Gaze-evoked nystagmus is a jerky nystagmus that occurs on extreme gazes, like if someone looks to the extreme lateral gaze or extreme up gaze. So this can cause some nystagmus movement in the eyes, moves towards the primary position, followed by saccadic movement towards the eccentric direction, leading to jerky nystagmus in the right gaze and left jerky nystagmus in the left gaze. So ask the patient to look to the extreme right, there will be right jerky nystagmus. Ask the patient to look to the extreme left, there will be left jerky nystagmus. And I will give you a little teaser. So can you tell me which kind of nystagmus that we mentioned earlier that will be very confusing with this kind of nystagmus, of gaze-evoked nystagmus? What kind of nystagmus that we mentioned before that can happen on the specific gaze? In what disease? So if I'm asking the patient to the right and the left, no, Dr. Hager, it is not Dwayne. Dwayne not causing nystagmus. Again, if I ask the patient, no, it is not Parinode. Parinode will cause a convergence retraction nystagmus. It is very different from the gaze-evoked nystagmus. Exactly, Dr. Ramya, it will be the INO or 1.5 syndrome. So there will be ataxic nystagmus of the contralateral eye of the affection of the medial longitudinal fasciculus. So if there is right medial longitudinal fasciculus lesion, there will be ataxic nystagmus of the left eye. So this ataxic nystagmus appears on abduction. So don't confuse this ataxic nystagmus of the abducting eye with the gaze-evoked nystagmus, because simply look to the right eye. you will find limitation of adduction in the INO. Okay, but this occurs bilateral in both eyes. So it occurs in, it is, as is the name says, it is gaze evoked, so it occurs on extreme gazes. Right jerky to the right or left jerky to the left. Other forms of nystagmus, the main thing or the main question in the exam they will ask about is the location. What is the location of lesion? What is the site of lesion in different cases of nystagmus? So you need to know these are the main cases of nystagmus with the location of lesions. So there's what's called the Brown-Cushing nystagmus. In this case, the lesion is present in the cerebellopontine angle, acoustic neuromas or meningiomas. Downbeat nystagmus, the site of lesion will be cervicomedullary junction, Chiari malformation, and cerebellar folliculus. Upbeat nystagmus, the lesion will be in the posterior fossa, caudal medulla, damage to the ventral tegmental area, anterocerebellar vermis. Torsional nystagmus in brainstem. Seesaw nystagmus in the diencephalon, paracellular lesion, pituitary lesion, optic chiasma lesion, periodic alternating nystagmus in the posterior fossa, vestibulo-ocular tract lesion, brainstem lesion, cerebellum region, convergence retraction nystagmus in pretectum or dorsal midbrain lesion or pinealomas, which is also present in the midbrain. Pendular nystagmus, which will cause blindness, optic neuritis, or for causes of blindness or sensory nystagmus, optic neuritis, multiple sclerosis, brainstem, cerebellum, dissociated nystagmus in the medial longitudinal fasciculus, or ataxic nystagmus of the contralateral eye. So let's review the important syndromes here. The seesaw nystagmus, it is a subtype of torsional nystagmus. So it is a pendular nystagmus. So to remember the pendular nystagmus, there are the sensory nystagmus, the seesaw nystagmus. So both of them are sensory nystagmus, seesaw and sensory nystagmus. So it is a sensory or it is a pendular disconjugate. The eye's movements are different. Why they are different? One eye elevate and intort, and while the other eye depress and extort. So like this. So see, check this patient. One eye will elevate and intort, and the other eye is depressing and extorting. Again. It is very minute movement. It has very small amplitude. So you may not be able to appreciate the movement, but it's present. Okay, so what are the causes of seesaw nystagmus? It will be due to large paracellular tumors such as craniopharyngioma or pituitary adenoma. There is another subtype of seesaw nystagmus. It's called the hemi-seesaw nystagmus. It is similar to seesaw nystagmus, but the jerky waveform is present rather than the pendular. So we said that the seesaw is pendular. If it is jerky, we say that it is a hemi-seesaw nystagmus. It can occur due to midbrain hemorrhage, medullary infarction, and Chiari malformation. Okay. What is the other type of acquired nystagmus? Oops. What happened? Let me just... everything is freezing. Okay, so this is everything about C-zone nystagmus. It's very important and asked in the exams. Always asked about the pituitary adenomas. So in the exam, they always wanted you know that the C-zone nystagmus is related to pituitary adenomas. Okay, the second one is, or the third one of the acquired nystagmuses are the downbeat nystagmus. Downbeat nystagmus, it is a jerky nystagmus which starts with upward drift of both eyes with corrective downward saccade. So slow phase up and then rapid corrective phase toward down. So patients usually are symptomatic from vertical oscillopsia. So the patient will, when he walks in the street, he will see everything is moving up and down. People, trees, cars, everything moving up and down. It is a vertical oscillopsia. And let's see how does the vertical nystagmus or the downbeat nystagmus looks like. So this patient has a downbeat nystagmus. Fast phase to the up and slow phase up and rapid phase down. The differential diagnosis for downbeat nystagmus can be very broad. Like it can be due to demyelination, stroke, trauma, drug toxicity, can be due to Arnold Chiari malformation, very important. And what's asked in the exam, this is the last sentence, that is due to lesion in the cervicomedullary junction. This is the most probable location of a structural lesion. Like for example, the Arnold Chiari malformation type 1. So don't forget, downbeat nystagmus, it is down in the brainstem, down at the medulla, the junction between the medulla and the spinal cord or the cervicomedullary junction. This is the downbeat nystagmus. If there is downbeat, so there will be upbeat. The upbeat is a vertical nystagmus, which with the fast phase beating upward in all positions. So you see the fast phase is up. So we name the upbeat or downbeat by the fast phase. If it is beating down, it is downbeat. If it is beating up, it is upbeat nystagmus. And causes for the upbeat nystagmus will be posterior fossa lesions, some drugs, and vernix encephalopathy. Okay. Another form of acquired nystagmus, which is the periodic alternating nystagmus. In periodic alternating nystagmus, it is a horizontal conjugate jerk nystagmus that has very nice character, or it is rare, but it has a very specific character. It is periodic alternating, meaning that it will beat in one direction for certain duration, then slow, then beat into the other direction into other for another duration. So it periodically alternates its direction of the fast phase. So for example, it takes 30 to 90 seconds beating to the right, then followed by 30 to 90 seconds beating to the left. And the two cycles of beating will be separated by a transition period, and at which there is no nystagmus or minimal nystagmus. It can be congenital or acquired, like so. Let's see this. Patients with periodic alternating nystagmus, the cycle starts by right beating. So he beats to the right. In order to diagnose those patients, you need to watch them for a while in the clinic for a few minutes to know the changing the direction of the nystagmus. So till now, he is beating to the right. This will be the half of the cycle, happening for 30 to 90 seconds. Still beating to the right. Now you can see that the nystagmus is slowing. let's see what happened. Okay, so it is slowing, and now after 15 seconds, the nystagmus reverse direction. Now it is beating to the left. You see that it is beating to the left, the fast phase. So this is the periodic alternating nystagmus. It is rare, but you need to have a high index of suspicion in order to diagnose it. So if you see it, it will be associated with CNS pathologies such as Chiari malformation or multiple sclerosis or stroke or phenytoin. Okay, so we finished now all cases of nystagmus, the different types like physiological, early onset, and acquired nystagmus. I hope that it is clear. Let's now discuss the treatment of nystagmus. So there are different lines of management depending on the cause. So there will be some pharmacological treatment. Mostly they are anticonvulsant medications such as gabapentin, baclofen, clonazepam. This can be used to control this nystagmoid movement depending on the original cause. And there is a botulinum toxin injection. So it can be tried, or some trials have been made to inject the botulinum toxin injection into the retrobulbar space to treat the symptomatic nystagmus. So some patients reported improvement of the oscillopsia. However, it can cause ptosis or diplopia, or interestingly, it can cause paradoxical worsening of the oscillopsia. So you are treating it for oscillopsia, but it's causing much worsening of oscillopsia because of the limitation of vestibulo-ocular reflex. Like when the patients who have oscillopsia have nystagmus, the physiological vestibulo-ocular reflex try to correct this oscillopsia a little bit. If you are injecting botulinum toxin, then you are paralyzing even this vestibulo-ocular reflex. Another treatment is if any patient with nystagmus that has a refractive error, this should be corrected. This is mandatory for patients, especially with infantile nystagmus. So you may say, but if a patient wears glasses, it will be difficult to be fixed over his face. That's why the contact lens may be useful for those patients, more useful than glasses. And they can be treated by the amblyopia therapy or occlusion therapy for cases of latent squint. And if the nystagmus decreasing with convergence, as in case of infantile idiopathic nystagmus or monoocular nystagmus of childhood, those patients may benefit from base-out prism. This base-out prism will induce convergence. Just hold on, please. Sorry for the interruption. So how to refract them using the retinoscopy, Dr. Hager. Using the retinoscopy, this can be done by retinoscopy to refract those patients. Okay, so if the nystagmus dampens with convergence, as I told you, we can use a base-out prism to induce convergence. This might help for those patients. And finally, the surgical correction. So the surgical correction, how do we do surgery for those patients? We do surgeries for those patients, especially for cases of infantile nystagmus, based on a surgical procedure called the Kirstenbohm procedure. What is meant by Kirstenbohm procedure? It is a resection of the horizontal recti in order to shift the null point from a horizontal cardinal position to a primary position. What does this mean? So assume that this question appeared previously in the advanced ICO exams. Assume that this is a patient who has infantile nystagmus, and you can see that he is moving his head to the left. He has a left face turn. This means that his null point is to the right. Again, if this child has nystagmus and he is doing left face turn, then this means that he has a right null point, or the null point is to the right. That's why he's moving his face to the left. And that's why he is trying to assume a null point in order to elevate the diplopia. Okay, so this patient is trying to relieve the diplopia. So how can we help him? How can we making this null point into the primary position? This can be done by doing horizontal recession and resection of the horizontal recti. Okay, so how to do so? If this patient is doing this face turn to the left, this means that there are more impulses are going to the right lateral rectus and the left medial rectus, so that then nystagmus will decrease. So more impulses are going to the right medial lateral rectus. Let me bring my pen. In order to assume this position, there are more impulses are going to the right lateral rectus and left medial rectus in order to have this position. So what I want to do is to do maximum stimulation of the right gaze, and also to do, so in order to do that, I will do right lateral rectus. I want to make the maximum stimulation to the right gaze. So by working on the right lateral rectus and left medial rectus in order to keep the eyes and the midline at the same position. So how can I do so? How can I make maximum stimulation to the right lateral rectus and the maximum stimulation of the left medial rectus and make the patient in the primary position, fix his face to the primary position? So in order to move both eyes to the left by right lateral rectus recession, weakening of the right lateral rectus, and right medial rectus resection, and the reverse will be in the left eye. So there will be left medial rectus resection and left medial rectus recession. Okay, so if I do that, if I do this kind of procedures, this will lead to movement of the both eyes to the left, so that the child will want to bring them in the midline again. So he will send more impulses to the right lateral rectus because I weakened it, and left medial rectus, so that this will shift to the eyes to the shift to both eyes to the midline and dampen the nystagmus. Yes, sorry, the left medial rectus recession. Sorry for that. It is the recession. Okay, left medial rectus recession. Okay, so by this way, we are moving the eye or making the patient trying to overcome this induced weakening of the right lateral rectus and the left medial rectus, so that he will move his move his head to assume the null position, which is in this case will be to the right. Okay. But there is a risk of ischemia. We try to, the risk of ischemia occurs if we operate on 3 muscles on the same eye. Here we operate on 2 muscles on the same eye. Okay, so no risk of ischemia here. Would you like me to explain it again? Yeah, sure. Let me clear this ink. Okay, so again, this child has a left face turn, so that this means that the null point is to the right. Okay, so this is the null point here. In order for this patient to assume this null point, I want to do maximum stimulation of the right gaze. I want to do maximum stimulation of the right gaze, and in the same way, I want the face to be aligned in the primary position. So how can I do so? This can do by the custom boom operation. Custom boom operation is based on the principle of resection of the horizontal recti. So in order to do this, I will do recession of the right lateral rectus, causing its weakening, resection of the right medial rectus, recession of the left medial rectus, resection of the left lateral rectus. So after doing this, the patient will send more impulses to the right lateral rectus and left medial rectus in order to overcome this recession, but this will result in eventually will cause the eyes to be aligned in them or to be in the primary position, so that the primary position is now will be the new null point for those patients. As after these surgeries, those patients after those surgeries will move his head to the left, causing the correction of this right face turn or left face turn. He will move his as the eyes are moving here to the right. After those surgeries, he will move the eyes to the left. Okay, clear? Any question? Okay, so thank you very much. We will stop at this level now. We will take the surgical correction of strabismus the next time. Thanks for attending and thanks for your attention. I wish that this lecture was helpful to clear a little bit of the confusion of a strabismus topic. And we will meet again next Monday to continue. So we'll cover the remaining the surgical correction of strabismus and the pediatric ophthalmology. Thank you.